Hi, everybody. Conscious that we're coming up to lunch, so I'm going to make sure that you get out there fine and early for it. I'm here today to introduce the work that we've been doing over the last number of months, which is to stand up the first 2 virtual wards in Ireland. So I'll give a very brief overview of what the ward is, our programme to date, how the ward will work, and the benefits of the virtual ward, which are from literature and evidence, but do need to be evaluated from an Irish context, and who the virtual ward is for as well. And if we do, what our approach will be to any scale up or extension of the programme. So what are virtual wards? Therefore, to support patients who would otherwise be in a hospital bed and that they can go home and be remotely monitored and receive treatment in their homes. It's another extension of work that's already going on. We're all aware of people that get interventions in their home from both the CIT, from public health nursing, a level of remote monitoring that goes on through some of the other clinical programs. And this is the next step in that. This is where a patient will go from an inpatient hospital bed home to a ward and remain under the care of the treating consultant that they were under in the hospital to finish out their episode of care. So what are the key features of it? So again, it's an acute-led service. So Deirdre McNamara will be maybe clinically deemed eligible to go home from hospital a little bit earlier and receive the continuity of her care at home under the virtual care of the consultant that she was in the hospital with, and also a nurse-led team. So that's the big key thing here, that it's 24/7. You're still deemed an inpatient in the hospital. And going back to Jackie's talk about HYPE, this ward will be classed as captured under HYPE as an inpatient ward. It'll be standardised name, and we will be able to extrapolate from the regions the activity in the ward. So it'll be St. Bridget's virtual ward, and that will be the national name for it, and you will remain an inpatient in HYPE. It's a time-limited service, so patients that will be selected to go into these wards will be going in with the viewpoint that they will stay 7 to 10 days average length of stay. And that's critical to this, because the productivity, the benefit, the value add to the ward is being driven by another tool to address capacity issues. We're all aware there's no one answer, but the virtual wards, the evidence to date has shown that they do have a practical role to play here in against real beds, in the absence of our real beds. As part of the initiative, we have funded a dedicated nursing and admin team to support the wards on each site. So the first 2 wards will stand up in Limerick, in Deirdre, and the second one on the other side of the country in St. Vincent's Hospital. The wards will be staffed by a WT complement of 15 staff, 14 of which are nurses and 1 which is admin support, like a ward clerk style. This will be all evaluated, and the additional skill mix maybe to support it will also be looked at that. The wards are funded to be 25 bedded wards initially, but they will stand up on a phased base approach. So we won't stand up 25 beds on a Monday morning. We might start off with 5, 10, 13. I know from other jurisdictions, we went over to Norwich to see their approach to it, and we very much adapted their model, and they scaled up on increments of 3 wards, 3 beds initially, and then once they got confident and the model became more mature, they were able to scale up more. We're going to roll out initially under 2 specialties, which is cardiology and respiratory. And we selected those with our clinical partners because they were deemed that the most suitable patients that would be eligible to go home early. So again, Deirdre goes in, she may have had some level of irregulatory heartbeat, she might have been admitted, tests all came back good, and Deirdre just needs to be monitored for a little bit more. So instead of keeping me in a bed for another 3 to 5 days, they can not discharge me, but admit me into the acute virtual ward to continue that monitoring. So it's for those type of patient, low risk but still requiring the acute care. of a consultant and a clinical team. It will use a variable combination of care technology, which will be a big element of it. We're currently finalising the procurement process for technology kit, and that will mean where the patient will go home with a little briefcase like of a blood pressure cuff, a thermometer and an iPad, where they'll be able to do virtual ward round, virtual consultations. And that will mean that the clinical team will have live clinical data of the person in the virtual ward. They'll be able to track and monitor their early warning scores. The patient, when they go home, will be able to contact the clinical team 24 hours a day if they're getting any concerns about themselves or if they have any symptoms that they would like to discuss. And they can come back in for face-to-face care or be readmitted depending on what's most appropriate. I won't dwell on this. It's a big, I just wanted to put it in that it's a massive programme. Even though it's just standing up 2 wards, it's very much front loaded. So the technology procurement piece was huge, and we're hoping that we'll be able to close that out and have some of our kits to operationalise at the end of June. So it was a very rapid, intense piece of work. We started early Jan with the target for operationalising Q2. And I love Liam's trick of where people email him to ask him how he's getting on, because I don't get those emails. Mine are much more specific. We had a steering group with myself and Richard Green, chair, and Richard is the chief clinical information officer, and we have 3 big working groups underneath it. One was the clinical SOPs, pathways, all the criteria for admission, the recruitment, because there was 50 WTs or aligned, or 30 WTs aligned to it, and then the technology procurement, which was one of the most intensive ones. Each site has a local implementation group. Limerick would have one, and they're headed up by the chief nurse. And we have a similar one in St. Vincent's Hospital. They're where the multidisciplinary discussions come. That's where the adaptation of any national standard policies and procedures that are developed, they're adapted locally and agreed through this group. So the ward objectives, like I said, is to establish 2, one in Limerick and one in Vincent's by the end of Q2, to develop and design an evaluation programme. And that really is for us to measure based on what we've read about. There's very little structured or specific benefits that are being able to be articulated. When they talk about readmission avoidance, it can go anything from 1 to 2% during COVID to 12 to 15% now. And when you drill it down into specialities, you kind of go up to 20% to 30%. So we just want to understand the value, that we're not sending patients on a roundabout, that they come back into hospital, that the outcomes are good for patients, that it's that there is that demand there, that there's the ability to put through on a 7 to 10 day average length of stay, and that it does create capacity in the hospitals, which is really what the key objective of these are. So how does it work? Again, I've kind of gone through it already. You're an inpatient in a hospital, and your clinical team will select you as part of a consideration that you would be suitable to go home in to the virtual ward. They'll talk to you, share information with you, and then the patient will consent that they're in agreement to do that. You're admitted onto the virtual ward, you remain an inpatient in the hospital, and you're sent home with your kit. And then you have management and monitoring. Again, I said there's that opportunity to engage if patients are concerned, and you're discharged from the acute virtual ward in the same way that you would be discharged from hospital into a continuity of care in the community, or just you're grand now, goodbye, and we'll see you in a long time. The benefits. So these are really, again, you could pick up, I think, a lot of papers and they would tell you 40 different things. They're new concepts. The NHS have stood up over 10,000 virtual wards at the moment, and they're still learning about them. So from what we understand to date is that it does quickly provide an increase in bed capacity. And that's one of our key, I suppose, focus points of measurement. that patients are more likely to be happy. They're going home, they're in their own home. You can go out and have a cup of coffee while you're in the virtual ward if that's how well and healthy that you are. You don't have to stay in a bed in your house. There's nobody going to knock on the door and say, Katja, you're not in bed. So it's really better for patients. They're removed from that risk of healthcare associated infections. And also staff, believe it or not, we were worried about because of the challenges of recruitment. And even in times of recruitment embargoes, we were worried that would we get the staff for it because there was such a high dependency on nursing. And they were all advertised, recruited, panelled with some to spare in a matter of 5 to 6 weeks. So it's because of the hybrid working that you can do this remotely as well. You're not physically on a ward, physically dealing with patients. So it really does show that high levels of staff satisfaction with this, because you have the best of both worlds. You still have that one-to-one engagement with patients. You're still bringing them back into an environment for tests if that's required. So it does look to be, we'll be very keen to see the outcome or evaluation on that. The treatment cost reduction, I'm sure I'm in a room where everybody would like to know what that equates to. And that's a work in progress. These are just some percentages that we have seen in papers of a 20 to 30% treatment cost reduction. And I think, first of all, we need to understand the cost, which is the staffing, the technology, and the non-pay cost, which is medication, potentially when patients go home, bringing patients back in. There are little hubs in a hospital. So in Limerick and in Vincent's, they have a little hub that the staff will work in, and they also have 2 little rooms beside it. So if Deirdre comes back in and I need an ECG or just a little bit of monitoring on a Holter monitor for a few hours, I have somewhere that I can go into. Usually they have 2 beds, etc. So we need to measure the readmission. So there's a lot of work there for evaluation, and we're very keen to have the opportunity to do that before we move into, I suppose, discussions and plans for scale up and the next stage of them. So again, the virtual ward, like we said, is for respiratory and cardiology. And these really are patients who would be at the end of their stay in a hospital. And that's what we're focusing on. In some jurisdictions, they have taken 2 approaches, which is admission avoidance and early discharge. So as we roll these out, we're going to focus on early discharge because we feel that's a greater measurement model, and we would hope to then expand the scope of them to admission avoidance. So future developments. So for us, like I mentioned, the evaluation model will be very important to us because we do need to understand that the investment does create value add to the organisation, to the site that they're in. And then the question is how to roll them out. You're not going to really recruit 15 staff for every 25-bedded ward. And we're going to measure them also to see, can we build the bed capacity? Can you scale up to 30 beds with the same staffing level? What additional staffing is required? Expertise in the line of healthcare, other healthcare professionals, physios, Occy Health. Pharmacy has been a big learning curve for us on this. So when patients are admitted into the virtual ward, what does medication management look like, and how do they get their medication when they go home? Do they go home with a prescription? Is that through community? So all of those costs and pathways are currently being worked out. Then also, do you scale up from central expertise teams? Do you build like a core clinical team that would cover a region and have maybe a staffing model that would have 60 beds? So all of that needs to be looked at, but I don't think it's to pop all the, that the staffing model and the current structure would be expandable out. UCD we partnered with to do the evaluation model. And in anticipation of the email that says, how are you getting on? We will also collect some monthly stats. And that will really be around throughput, demand for the virtual ward based on the SOPs, because these are for low risk, low acuity patients. And so that's really it.